Hi, good morning class. We are the second team and today we are going to talk about the Helicobacter pylori. Please, question will be at the final of the presentations. And, first, introductions. The Helicobacter pylori is a bacterium macroaerophilic gram-negative, slow crawling with the highly conformed and 4-6 free major 3 microns long, diameter of 0.5 microns, and this is the form. It was discovered by the scientists Robin Warren and Barry Marchant in 1982, which was worth the prize Nobel to them. Helicobacter pylori is a bacterium that has a direct relation with the development of the gastroduodenal disease. The infection is acquired in early ages, usually in kids and to a lesser extent in adults. Is found in the stomach, a large part of the population in less developed countries. And the epidemiology affects 50% of the populations, 3 out of 10 people, is classified as a type 1 carcinogen, and in Mexico, the prevalence of infections is 70%. But is acquired or genetic? The infection is acquired in early ages. In its pathogenia develops an immunological answer, which takes to inflammations and erosions of the gastric mucosa, which leads to the formations of ulcer, chronic gastritis, and possible gastric cancer. This way, the corresponding clinical manifestations appears according to disease: pains, sickness, dyspepsia, loss of weight. Its acquisition is related to poor socioeconomic conditions, poor hygiene, overcrowding, oral injections of the bacteria, instrumentalizations, endoscopies, and gastric tubes, fecal oral route, smoke, and breathe beer. We can find Helicobacter heimani in dogs, cats, pigs, and primates, but its finding in humans is 0.5%, causing only mild gastritis. And, White H. pylori survived into the gastric mucosa. This survival of the germ in the gastric mucosa is carried out by 1. Addisons. Addisons thus prevents big rack by peristalsis. 2. Bacterial enzymes such as, for example, urease that converts urea to ammonium, producing alkalinity that protects from gastric acidity. 3. Lipase and proteins that break down gastric mucus and the ability of mucous cells to secrete mucus. And finally, catalase and superoxide dismutase as a lines of defense against polymorphonuclear cells. The associations and indications. The colonizations for Helicobacter pylori induce an inflammatory process in the gastric mucosa, predominant in the gastric antrum, and is the main cause of chronic gastritis and is associated with the development of ulcers, atrophia, intestinal metaplasia, gastric adenocarcinoma, and lymphoma of the lymphoid, associated with the gastric mucosa with its initials MILT, MALT, and causal association with peptic ulcers disease, 19% duodenal ulcers, and 18% gastric ulcers. Most of the patients with chronic infections by pylori do not develop EUP, and individuals with background of ACG, first-degree family members, have 7 times more risk, and treatment, this is give treatment. This is very important. Give treatment. And the role of H. pylori disease as an etiological agent of or specific symptoms in the pediatric populations, and is a risk factor for ACG in 19%, and MALT, MILT, in 19.2%, and 6. Mexico is a country with ACG risk profile associated with the H. pylori, a low level, for example, 5.6, 7.5 for every 100,000 inhabitants, for example. Long-term treatment with IVP alters the topography of H. pylori. 8. The eradication of H. pylori is the first line's treatment of low-grade MALT, and finally, is associated with anemia and purple thrombocytopenia.
H. pylori infection can be diagnosed by invasive and non-invasive techniques. Non-invasive tests and treatment strategies are widely recommended in the primary care setting. Among these are serology and the urea breath test. In the case of serology, the ELISA test detects IgG or IgA direct against HP-specific antigens, so the sensitivity and specificity are greater than 90%. The eradication of HP is associated with a slow but progressive drop in titers, so most tests will be negative as long as 6 months or a year after effective eradication. In the case of urea breath test, using non-radioactive C30 or C40, decay is detected by the urease of the HP, the marked urea ingested by the patient. Sensitivity and specificity is comparable to serology, with the advantage of being able to confirm eradication 4 weeks after finishing therapy. The invasive tests are urease test in antral biopsy, histopathology, PCR, culture, helicoblood 2.1 test. About the culture currently doesn't have an important role in the diagnosis due to its slowness, and in many laboratories its sensitivity is less than the histology. The urease test in antral biopsy. The urease produced by HP converts urea to ammonia and dioxide carbon, which modifies the pH of the medium and causes the color change that defines the reaction as positive. Histopathology is the gold standard for defining presence of HP, staining the sample with GEMSA. The sample should be taken in the healthy antral mucosa, avoiding the pyloric region in the lowest part of the minor curve. PCR. For its sensitivity and specificity, it could become the future standard method, although HP's ubiquity may generate problems due to false positives. Helicoblood 2.1 test is a serological test used to detect IgG-type antibodies to specific HP antigens.
Now we continue the treatment. If it's not possible to access antimicrobial resistance, must be considered use a second-line scheme which includes high dose of PIB, amoxicillin, bismuth substrate, and a second antibiotic that has not been included in the first scheme. Now, we can see the table when the treatment regimes are like clarithromycin triple, bismuth quadruple, concomitant, sequential, hybrid, levofloxacin triple, levofloxacin quadruple, and load. In regions with rate of resistance to clarithromycin equal or higher than 15%, the triple scheme with PIB, amoxicillin, and clarithromycin must not be used. In regions with clarithromycin resistance rates greater than 15%, it is recommended to start with quadruple schemes. In regions with high dual resistance rates, clarithromycin and metronidazole, as in our country, recommended as the first line. The quadruple therapy for 14 days, being able to consider two options. Option 1. Quadruple therapy with bismuth is PIB or proton inhibitor bomb, bismuth substrate, tetracycline, metronidazole. Option 2. Quadruple therapy without bismuth is PIB, amoxicillin, clarithromycin, and metronidazole. If the first-line eradication treatment fails the antimicrobial susceptibility of the H. pylori strain, must be studied isolated through endoscopy with sample taken and cultivation to adjust the treatment and improve the eradication rate. In cases of penicillin allergy, use is recommended the quadruple scheme with bismuth. Now, here we can see the algorithm that is used in current Mexico. That is the same in another places of the world. We continue with public health. In Mexico, the prevalence of H. pylori infection in 1998, after 10 years, 50% of the children were infected by H. pylori at 20 years old. This figure reached 70%. 10 years later, the prevalence dropped 10% in young adults and 15% in children between 11 and 14 years old. The eradication of H. pylori reduces the inflammatory response, and when the treatment is timely, decreases the risk of progression to premalignant injury, atrophic gastritis, and intestinal metaplasia. The eradication of broader pylori prevents HCG developed in cost-effective in high-risk geographical areas. In Mexico, not recommended eradication of H. pylori in general population as a strategy to prevent HCG. The presence of pre-evil induced atrophy or intestinal metaplasia requires proper histological stratification and periodic surveillance.
That's all. Thanks for your attention.